How many of you have ever, in outpatient therapy, written a progress report that succinctly and that within 1, 2, 3, 4 lines of text, an entire progress report is complete? What's going on, guys? So this is a supplemental guide to my Zero to Paid Medicare Billing course, the documentation modules. Behind me on the screen right there, you can see CMS Chapter 15. We are open to page 180 in the document, and we're starting at section 220.3, documentation requirements for therapy services. So this applies across the board to all three disciplines: speech, occupational therapy, and physical therapy. I want to just kind of run through this. It's absolutely worth reading independently, but let's go through some of the highlights together so you don't miss anything. Essentially, it discusses this is the minimum expectation of documentation for providers and suppliers. That being said, this is what Medicare is saying is required. Now, contractors shall consider the entire record when reviewing a claim for medical necessities so that the absence of an individual item of documentation does not negate the medical necessity. This is important. I want you to think of your medical record as a book, a novel. There's lots of chapters, lots of components. So maybe you miss something in one section, but you bring it in another section. Now, that being said, every great book has a table of contents. Every textbook has an index. Make it easy for the reviewer to find the information. Don't bury it. Don't hide it. Start with the bare necessities, and then you can expand from there if you believe is necessary. And don't do documentation absent of context. There's a huge difference in the expectation of documentation for a single visit plan of care versus a 36 visit plan of care. So take into account the big picture of everything that's going on with a particular patient. So let's take a look at what is actually required. There needs to be an initial evaluation and plan of care. This can be one single document or two separate documents. I can tell you that in my practice, we typically combine the evaluation and the plan of care into a single document. But if I have clinicians who are struggling to get the documentation done within the session, we can split the evaluation and the plan of care. If you look at the requirements for the plan of care, there's only 3 core components that are required. The plan of care is what needs to be sent to the physician, signed and returned to qualify as a certified plan of care. All you need is a diagnosis, long-term goals, and then type, duration, and frequency. And that basically what that means is physical therapy, how many times a week for how many weeks. Type is the discipline that you're providing. So if you need to, you can split those documents. You can do your evaluation as a separate document from your plan, but the plan is what needs to go to the referring provider, go to the physician, non-physician practitioner to be signed and certified to maintain your compliance with the Medicare regulations for Part B services. So certification. This is where we look at physician, non-physician approval. There's guidelines on what is a timely certification, how much time you have to get it returned, what you do for delayed certifications, what happens if you can't get a plan of care certified. We need a progress note, which they refer to as a progress report, a discharge summary, discharge note. They are progress reports. Progress reports, and you'll see through this lesson, do not need to be signed by the referring provider unless they are changing the established plan of care. And I'll give you some examples of what that would look like. But generally speaking, the progress report needs to be done at least once within 10 sessions. It can be done sooner. It cannot be done later. And it does not get signed by the physician or referring provider unless it significantly changes the original plan of care. Treatment notes. Treatment notes must be provided for each treatment day, and they may also serve as progress reports when the required information is included. So again, at our practice, we combine the need for a progress report and a treatment note into all of our documentation. If we have a major change to a plan of care, if we're extending the date range, if we're adding a new diagnosis, we're doing something that significantly changes the plan of care, we create a separate progress report that does go to the referring provider for signature. But under normal situations, our daily note and progress report are combined documents, and our treatment note contains the information that would be required normally for a progress report. And then finally, Optional, separate justification statement may be included either as a separate document or within other documents. So typically what I say is I've been, in the therapy business for over 20 years. We've had a private practice since 2002. I've been a licensed therapist since 2006. Even with the history that I've had, I don't believe as a therapist that I can adequately evaluate an individual patient within a single session. The reality is that first session is going to be a combination of the patient telling me what they think I want to hear, me trying to extract the information that I believe I need, me trying to understand the entire context of, patient's social support system, patient's fears and anxieties, the history of the current condition, all the comorbidities, all the complexities. There is no way in 60 minutes I can adequately assess and develop a reasonable plan of care, a detailed plan of care. So instead, what I do is I meet the bare necessities, I meet the minimum expectation of documentation, I get the certified plan of care taken care of, and then if I need to, I add this kind of supporting documentation so that there's a minimum viable product for an initial evaluation done and in the medical record, but then I continue to add information during the next series of treatments. And the way I try to set up my plan of care, my eval, my documentation is, again, I use the idea of a novel. So I have the initial evaluation from which I develop my plan of care. My plan of care essentially lays out long-term goals, short-term goals in a series that's consistent with a table of content for a book. Each chapter is a goal. Each chapter corresponds to a treatment. That treatment is consistent with the objectives of that goal, so that if I do 4 short-term goals, which for the record, you'll see in the documentation, short-term goals are not required, but may be utilized. So I tend to do 4 short-term goals, 4 long-term goals. That gives me 8 total goals. I know that a progress report is due within 10 sessions, depending on the plan of care. So what does my documentation, my medical record look like? Well, we've got session number 1, the initial evaluation, the initial treatment. Session number 2, first follow-up, addresses short-term goal number 1. Session number 3 addresses goal number 2. Session number 4 addresses goal number 3. Session number 5 addresses goal number 4. Those are the chapters in my book. I've addressed each one of those chapters, and each daily note focuses on those goals. I'm 5 sessions in. I've got 5 to go before a progress report is required, but in each one of these treatment notes, I've addressed a component that would be required in the progress report. Then we've got long-term goal number 1, session 6, long-term goal number 2, number 3, number 4. So I'm at 9 sessions. I've done the initial evaluation, all 4 short-term goals, all 4 long-term goals. By session 9 or 10, I've addressed everything that would be required in the 10 visit time frame for my progress report. Now, as I said, it depends on the context of the referral. If this is a one-time visit, home exercise program, a little bit of education, I'm not going to see him again. It's one goal. Get him a home exercise program. Teach him. Let him discharge. If it's a 3-session plan of care, obviously I'm not doing 10 sessions if the plan of care is 3. So I do the eval, initial treatment, I address one goal, I look at a discharge summary, right? But if it's a longer program, if it's a 12 session, 24 session, 16 session, I'm going to be doing the progress report in there. You're going to see in the guidelines that you can create a plan of care that is certified up to 90 days. The plan of care might be 6 months. It might be 12 months, but the maximum certification is 90 days. If you make a plan of care for 4 weeks, it expires in 4 weeks. So just understand these guidelines, and that's why this document behind me is so important, because all of your questions are going to be answered in this document. You just need to understand how to find it, how to read it, and then how to apply it to real world situations. So that's what we do in the Zero to Paid Medicare Billing course. We take the information straight from the Medicare, we apply it to real world situations. What does a real note look like? What are the minimum components of a real note? I'll give you another example kind of before I wrap this video up. So specifically talking about progress reports. In this document, it goes through all the requirements for the eval, for progress reports. Forgive the scrolling, but I want to get down here to progress report. They have an actual example. So here is the section on progress reports. And often therapists come to me because they want to bill a reevaluation routinely in place of doing a progress report. Well, It's not. A reevaluation is a completely separate billable service that is not a progress report. But therapists believe because they put so much effort into doing a progress report that it deserves to be billed separately. Well, it doesn't. Here is the published example of a progress report. So this is the context that Medicare provides. This is not a progress report. The example of the progress report is actually what I've highlighted here. So for example, progress report for January 3rd to January 29th. A component of a requirement for the progress report is the date range it covers. That takes care of checkbox number 1. The number 1 here is referring to goal number 1, improved to 80% of trials. So they're saying whatever goal number 1 was, it was improved to 80% of trials. So you don't have to rewrite goal number 1, you simply have to indicate the progress. The 2 refers to goal number 2, achieved. Again, don't rewrite the goal, don't give narrative, don't explain anything. Achieved. The idea here is a reviewer can look at this, look at the guideline, and check a box. Did the clinician indicate the date range? Yes or no? Check. They could have made this narrative 3 sentences, 20 sentences, or 6 words. They chose to do it briefly and succinctly. It doesn't matter. It still gets a check. Did the clinician address the goals? Check. Added comments, highly motivated, spouse assists with participating, compliant with current restrictions. Okay. New goals. So in this particular progress report, they're even adding new goals. Patient will implement above strategy to swallow a sip of water without coughing 5 consecutive trials. And then they sign off, Mary John's, SLP, and the date the note was complete. So within 1, 2, 3, 4 lines of text, an entire progress report is complete. Now, I don't know if this was for 10 sessions, for 3 sessions. I don't know how this went. But the point is, this is Medicare's example to you of what an adequate progress report is. I would love to hear from you guys. How many of you have ever, in outpatient therapy, written a progress report that succinctly and that in that short of a space? My guess is I'm going to see a whole bunch of nevers in the YouTube comments below this video. So guys, think about this. This is where getting the professional experience, whether you go to Rick, whether you go to Nancy, whether you see me, there's other providers out there. Find someone who has been doing this longer than you, who can share their practical examples with you and can show you the reference. You know, none of this is my opinion. I'm not telling you what I think. I'm showing you the reference and the guideline, and then I'm showing you examples that comply. So guys, as always, thank you so much for watching. If this was helpful, like the video, share it, subscribe to the channel, and let me know in the comments, I'm serious, have you ever written a progress report that succinctly? I'll catch you on the next video.